Welcome to BW Healthcare World. Today is World IVF Day, and we are proud at BW Healthcare World to bring to you some of the most seasoned and respected professionals in their respective fields related to IVF to come and have a conversation that could be useful to each one watching this show today. India's IVF market has been growing exceptionally at a very fast rate of almost 16.5%. The market that was estimated to be 793 million way back in 2020 is estimated to grow to 3,020 million by 2030. We have in our country over 2,500 fertility clinics, second to only US in terms of number of cycles being conducted in India. We're conducting about 2 to 2.5 lakh cycles for IVF every year. We have heard doctors stating that the success rate is now around 50 to 60%, which is commendable. And in terms of women who are a little younger, it can go up to 65%. Now, why are we seeing the industry grow at this fast pace? Well, there are three aspects to it. One related to what is happening from the patient's perspective, and then we have the perspective of why the industry is growing. From the patient's perspective, one of the changes that we have seen in our society is that there's a concept of marrying late, which has increased the average age for pregnancy in our country. This has raised the fertility issues, which are now becoming a concern in the country. The second thing that is feared to cause infertility is growing stress levels. Whether it is true or not, we will understand from the experts that we speak to today. The other thing that has increased the number of IVF cases is also that now people have a larger disposable income available to them compared to what it was decades ago. The general awareness about options available to people who were dealing with infertility has grown. The acceptance of infertility, which has brought us to a point where people are openly discussing it, has gone up. And the tech advancement in this area is helping the industry raise the success rate. So there is a more acceptance in terms of getting IVF done. Now, when it comes to the industry perspective, when the need for some procedure or need for certain treatment is growing, obviously this is seen as an opportunity to scale practice in this expert area. And when there is more demand and there is a need to grow the practice and there is growing acceptance for that treatment, the investors take notice and are pumping in their investments in this area. Today, on the World IVF Day, we have a very strong speaker panel which will help us understand and know what is IVF. What are the causes for infertility? We'll try and understand if there's a role that stress plays in growing infertility, or is it the infertility which is leading to stress? We will also try and clear certain misconceptions that people have about infertility. So we will be busting myths with respected and experienced IVF specialists. We will also understand the legality and regulation around ART. And I sincerely believe and hope that this show or a virtual event hosted by VW Healthcare World will be useful to anyone who's going to be watching this show. My humble request is do subscribe to our channel. We keep doing these kind of events which are known to be useful by people who are enthusiasts about healthcare, by people who are dealing with conditions but are finding it tough to get answers from experts. That's what our endeavor is, to be useful to the healthcare industry, to be useful to the patients, helping people live better, helping people have faith in the medical system of today. I wish every IVF specialist the best on this World IVF Day, and I pray that the patients or the couples who are dealing with infertility find the information that is shared by experts today on our show useful or whatever they choose as a treatment. Thank you. So welcome Dr. Malpani to VW Healthcare World. It's the World IVF Day and it's such a great opportunity to have you with us. I'm sure this conversation will be very useful to our audience. So thank you for joining us.
Thank you. I'm really happy to be here and I'm looking forward to this.
Right. And Dr. Malpani, you have written a book called Cries, Sighs, and Lullabies. I've gone through that book. That book is very, very useful to anyone who reads it, and especially for someone who's considering IVF or is pregnant, use ACTs. My question to you is, what are some of the social dilemmas that play a role in fertility issues that we see in India?
So basically, our society, the Indian society, is a patriarchal and a very pro-natalist society. Women are looked only as childbearers. We are not looked upon as somebody who's achieved or who they are or what they are, unfortunately. In fact, when they do not have children, they face more problems. Very often, they're looked down upon, they're discriminated, they're ostracized. And this leads to a whole lot of negative emotions, negative impacts like anxiety, depression, sometimes to a point of suicide. In cities, it's not so bad, but yes, the shame and the stigma of infertility is yet around. Though we call our society very progressive, the shame is very much there. People yet don't share the fact that they cannot conceive within family members, close family members, relatives, friends, at work. And this leads to a lot of problems. For example, they get delayed treatments, wrong treatments, misdiagnosis, actually creates harm to the couples. So, and in villages, it's even worse because that's the place, where they're not allowed to, they're discriminated. Like I said, at times they're even tormented and tortured. So I think, infertility is just not a medical disorder. It's very much an emotional, psychological, and a social one.
And Dr. Malpani, in India, because of these social issues, the first belief is that the problem has to be, the medical problem has to be with the woman. But many a times the challenges could be with the men. And one of the biggest challenges when it comes to fertility related to men is the lower sperm count. Now, what are the options available to a man in case of a low sperm count? Is it true that, if you're with low sperm count, he cannot ever become a father? Or is there some options that are there to help the person out?
In fact, in today's day, it's better to have a sperm problem or a low motility because that's the easiest problem to solve. The technology has advanced so much and a term called ICSI, intracytoplasmic sperm injection, is a higher form of IVF. It's one of the assisted reproductive technology where even a man with a very, very low sperm count, just to give a background, a normal sperm count is defined as one which is more than 15 million per ml with a motility of 40%, where they're progressive motility. So even if a man today has 1 million or even less than that, with ICSI, we can, he can father a baby. And let me tell you something interesting. A man with a zero count also can father his own baby today by a technique called TISA-ICSI, that's testicular sperm extraction with intracytoplasmic sperm injection. And I'm proud to say that my husband Anirudh and me were the first in India in 1996 to do this technique. And since then, it has absolutely revolutionized male infertility. So men don't have to be worried at all about. In fact, I'm happy when it's a male problem rather than, something else. So it's very easy. And intracytoplasmic sperm injection has changed the technique because in IVF, we require millions of sperms. Basically, we take an egg, we take 10,000 sperms per egg. So when you have about 10 eggs, we require millions of sperms. But the equation has changed totally with ICSI, where we get only one egg and one good motile sperm is equal to one embryo. So the whole scenario has changed with a treatment called ICSI.
And Dr. Malpani, there are cases where IVF fails. And then suddenly something which is a lower treatment, IUI, works out for the lady.
It's quite common.
Is this possible? And what I really want to know is, one, is it possible? Second is, if it is, what are the lifestyle changes that the couple needs to make this possible?
Yeah, what you're saying, it happens if you do IVF. There are many reasons to do IVF. One of the reasons in the past was blocked tubes, when both the fallopian tubes are blocked. Now, if IVF is done for that reason, then obviously the woman cannot get pregnant with IUI. But let's say the IVF was done for other reasons, for example, unexplained infertility, which means though everything is normal in the couple, but yet they're not getting pregnant. If the woman has, say, endometriosis, which is mild or moderate, or even sometimes severe endometriosis, or if the age of the woman is on the higher side, plus 35, 38, or if it's a male infertility with a borderline sperm counts, if these are the reasons, then IVF can fail because IVF is not 100% successful. Even with the best of the embryos and any number of embryos which we used to put in the past, not anymore, IVF can fail. That's a myth that, if you do IVF, it's 100% success. So even if IVF fails, and if these are the reasons, to do IVF, then once you stop IVF with an IUI, if both the tubes are open, if it's a borderline, sperm problem, then you can suddenly get pregnant. So that's quite okay. And the lifestyle, yes, people do need, because today we are seeing that the sperm counts are falling. And one of the reasons, other than pesticides, plastics in the environment, it's said that it's lifestyle, changes have to be done. Smoking is important. Smoking can actually reduce the motility. So we've seen heavy smokers who have a very low motility. The husbands, of course, they don't agree to it that they're heavy smokers, which is about maybe 10, 20 cigarettes a day. So when they stop smoking, immediately their motility goes up in 2-3 months and they can get their wives pregnant. Alcohol per se doesn't cause a low sperm count, but it does affect the sexual life. And sometimes there are erectile dysfunctions and other problems. So it does affect. Obesity is, again, similarly, it can affect the sexual dysfunction. There are hormonal imbalances. So one needs to obviously, change these lifestyles. Drugs like marijuana, cocaine are also known to decrease the motility and the counts. So people need to have good habits.
What about stress?
So that's been a question which has been debated over the years. So does stress cause infertility, or does infertility cause stress? So it has been proven that infertility definitely causes stress, because people, there have been studies done where there is anxiety, there's depression. But unfortunately, there are no studies which have actually shown that stress causes infertility. And let me tell you something. If stress was causing infertility, then women who get raped wouldn't get pregnant. Women who are in the jail wouldn't get pregnant. So I'm not saying it's a big no-no, but yes, stress per se doesn't cause infertility. If a woman is very, very stressed at times, yet, and for a long period, yes, some women do get ovulatory dysfunction, which means they stop ovulating an egg for a temporary period, and they may have, issues, but it's not a permanent problem. So right now, I don't think that stress really. Though it's very easy for doctors to say, "Ha, stress hai," don't get stressed. Today, even school kids are stressed, right? So,
and Dr. Malpani, the other thing that people have, put in their mind is that do teen cycle kar liye, I've already tried it. Now it's not possible. And second is, it is not safe to do beyond 3 cycles or something. Is that true?
Yeah. So the commonest question that is asked, doctor, how many cycles? And that's again $1 million question. And I always say, till your pockets are empty, I think you can try. Of course, I mean, there are some women who physically cannot take the hormonal injections, do the pickups. Some people get mentally stressed. But there is no right number. It's not like you have to do, if you don't get pregnant in 4 cycles, and now that's it, there's no need. In fact, in my book, Try, Size, and Lullabies, there's a story which says it's called the magic number. And that woman has come from Australia in the past, and she's done 18 cycles of IVF. There are 18 egg retrievals, and finally she's pregnant with triplets with us. So there is no right or wrong, unfortunately, and it does not cause the harm. Now, it's a very, very common misconception that hormonal injections will harm you. But it's a very temporary treatment which is done for 10 days, 10 days, you take the injections. There are no long-term effects. This has been well proven in journals and all over the world that hormonal injections do not cause any type of cancer, which is a common misconception that it causes breast cancer, ovarian cancer, uterine cancer. But that is well proven that it does not cause any form of cancer, neither does it have. And there are very few in fact, there are no side effects, I would say. But some people do complain. I would say the husbands complain that there are mood changes in the wife. That's probably, and of course, if the injections are given, I mean, if it's not monitored and there are too many eggs, there are problems of hyperstimulation where you grow too many eggs. But in a good clinic with a good doctor nowadays, the hyperstimulation rate is almost zero. In my clinic, we've had no hyperstimulation for the last 10 years or maybe more. So, that's not, that's why I said it's a good doctor in a good clinic. The risks are almost zero. So,
And Dr. Malpani, let me come to the sperms again. And, there's a concept of freezing the sperms, right? So first dilemma that people have is that, is the frozen sperm of the same quality as that of a fresh sperm?
Yes, absolutely. There is no difference between a fresh sperm and frozen sperm. It is kept very well in minus 196 degrees liquid nitrogen tanks, and a frozen sperm is as good as a fresh sperm. So because of this technology, in fact, again, we are the first in India to start a sperm bank way back in 1990 when it was taboo. The word sperm was not even to be spoken. I remember when my article came on the front page of Times of India, couple starts India's first sperm bank. My mother picked up the phone and fired me. She said, "What are you doing? How can you do things like this? Or even how can you even say the word and give interviews?" So anyway, but coming back to the questions, it's very safe. And because of this technology, today husband and wives don't even stay together. One is in USA, one is in Hong Kong, one is in, say, Jabalpur, one is in, Trivandrum. You can just give a sample as and when. We don't need husbands anymore for the IVF cycle or for an IVF cycle. And this was quite common in the past. Also, even now, a lot of people who go on the ship in the Navy, they freeze their sperms because they leave their wives for very long, for a few months. So technology has helped us to achieve this.
I mean, one more related question that comes to our mind is that a lot of people have been using donor sperms. Now, donor sperms,
yes.
Right? Now, are these donor sperms good to be used? One. Second is, what could be the risks? Because, there are questions around the health of the person. There are questions around the HIV, etc. So when can these sperms be tested? And secondly, for how long should you wait before the sperm can be used as a part of the IVF process?
So for donor insemination, use of fresh sperm is a big no-no. And that is the reason why we started the sperm bank, or there are sperm banks in the world, because fresh semen cannot be tested for HIV. It is the man's blood that is tested. The antibodies appear after 6 months, as everybody knows. So you cannot use fresh semen and say, oh, I've tested the man, because the antibodies will not show up immediately. And that is why there is a procedure when we take a donor sperm, is we take the sperm, we see that the sperms are of a high concentration. So if a normal count is say 15 million, then we go up to 50 million, 60 million, 100 million. In today's day, it is very difficult to see 100 million because sperm counts are falling, like I said, So we go say maybe 30, 40 million. So now these sperm, once the sperm test is normal, then we take a detailed medical history of the donor, which means the medical background, diabetes, hypertension, whether he's had HIV, sexually transmitted diseases. These are the tests run on him. So we test him for hepatitis A, B, C. We test him for sexually transmitted diseases, HIV. We do the routine tests, the blood checkups on him. And once he's okay, he gives a sample, which is kept in the sperm bank for 6 months. The HIV testing, once it comes negative, then we test him again after 6 months. And if the antibodies are negative, then only can we use that frozen sperm. By any chance, if the antibodies come positive and HIV positive result comes, then we throw away that semen sample. So this is the purpose of a sperm bank. So there is no risk in using a donor sperm.
Right. And Dr. Malpani, one of the other questions that is very commonly asked, or a challenge that is there in the mind of the women, is that when we get pregnant using IVF, the chances of miscarriage increases. Is that a reality?
No. The IVF procedure itself does not cause a high increase of miscarriages. It is the same as in normal population. But very often what happens is the underlying disease or the underlying conditions why we do IVF causes the miscarriages. For example, if a woman has if a woman has endometriosis and she's doing IVF, then endometriosis is known to have a higher rate of miscarriages. Again, sometimes we do it for PCOS, that's polycystic ovarian syndrome, which is very, very diagnosed in almost all young girls and all women now. So sometimes if they don't respond to tablets and injections, we do IVF for them. PCOS are known to miscarry. So it's not the procedure itself, that's a myth again.
And Dr. Malpani, until what age do you think, as a expert and skilled practitioner for so many years, is it safe for women to go for IVF? I would even, rephrase it. It's not just the safe. Until what age do you think IVF is a treatment that could work for women?
Is it the age of the women or the men? It's different.
You can tell us about both.
Yes, as usual, the women take the brunt of it. So the woman's age is this is the only crucial factor in treating IVF. A single factor which is important is the woman's age, and the success depends wholly on it. So now the woman's age, the peak fertility in a woman is between the ages of 20 and 30. So ideally, a woman should get pregnant. In the past, they would get married early or get pregnant, as soon as they got married. It's not happening today. People are getting married late. Women are getting married late because of careers, because of traveling, because of studies, or just want to have fun, basically. So this is a problem. So peak fertility is around maybe the ages of 30, and it starts declining at the age of 35. 35 is not a magic number, but around 35, when the egg quality goes down and the number of eggs goes down. As you reach 40, the fertility declines very rapidly. So the best age to get pregnant, I would say in today's days, would be around between 30, 32, 33. I have women who come who are going to be, their birthday is in like 6 months. Oh, I'm going to turn 35. Oh my God, my biological clock is ticking away. Doctor, get me pregnant. I want to do IVF. It's not a Hindi movie. It doesn't, you can't get pregnant. A few lucky women, of course, get pregnant in the first cycle, but it takes a few cycles usually. So the success rate also falls down. And I want to make this very, very a big message to the young women out there that yes, you can follow today. Biology is not destiny. People would be resigning in the past. Today we have technology. You can take advantage of the technology. You can freeze your embryos and keep. You can freeze your eggs and keep. If you do not want a baby now, or you haven't found the right partner, or you want to do your careers or your studies, whatever, but come at the right time. The right time to come for freezing eggs is also around 30, 32, 33, and not at 38, 39 when the egg quality has gone down. So today, things are possible.
Right. Dr. Malpani, my next question to you is that, there's this term called ectopic pregnancy. What is it? And what are the chances of ectopic pregnancy? And if a woman has experienced this condition, what are the chances of it repeating if she gets pregnant the next time?
So ectopic pregnancy basically means the word outside. So when the embryo is formed, normally the embryo is formed in the fallopian tube, and then it comes back and is implanted in the uterus. That is what happens naturally. Sometimes the embryo doesn't come back into the uterus, it remains in the tube, fallopian tube itself. Probably because the tubes are not good, they're damaged, or they're physiologically not functioning. And that's when the embryo gets stuck in the fallopian tube. It's known as an ectopic pregnancy. The commonest place is the fallopian tube, but sometimes the embryo comes out of the tube, can get implanted outside the uterus too, in the ovaries, sometimes in the lower part of the uterus called the cervix. Those are rare ectopic pregnancies. The commonest ectopic pregnancy is a tubal pregnancy, and that can be life-threatening. So that has to be diagnosed very early. Today we have technology with a simple blood test called beta HCG. When a person misses a period, we can say yes, she's pregnant, and then do an ultrasound, as early as 1 week after she's missed a period, and you can see that the pregnancy sac is inside the uterus. So today it's not so bad as long as you're aware that, it could be an ectopic pregnancy, and there are treatments today. The chances of having an ectopic are maybe one in, maybe about 5 in 100 people may have an ectopic. It's not that common, and it's not that rare either. And yes, the saying does go that once an ectopic, a second ectopic is common, because the very reason that she got an ectopic is probably because of faults in her tubes. So that's quite common. So one has to be very, very careful when she gets pregnant the second time. Monitoring of the pregnancy is very, very important.
And Dr. Malpani, the other very common condition among women who are trying to get pregnant is PCOS. So my question to you is that does PCOS mean that the woman will experience fertility, or is just that she has more chances of facing infertility? And second is, if a woman does get pregnant through whatever procedure, if she has been a PCOS patient, are there any challenges that she might face during that pregnancy?
Yes, the PCOS, like I said, is a very commonly diagnosed disorder in almost all women. I think now young girls are getting diagnosed as PCOS, unfortunately. That's because, they have a little bit of acne. They run to their dermatologist or cosmetologist who says, do a scan, and then it turns out to be a PCO, then you go to a gynac. So, they are being diagnosed quite a bit, and it's not common, but the diagnosis is getting more common. It's a myth that all PCOs are infertile. A lot of them get pregnant at home in their own bedrooms. Sometimes, of course, PCOS do have hormonal disturbances. So basically, the male hormone, that's the testosterone or the androgen hormones, are higher in them. And that's why they have ovulatory dysfunction. So very often they miss a period, they have irregular periods, and they don't get pregnant because they don't ovulate every month, or they have no ovulation. But these are easy problems to solve with a simple tablet, sometimes with injections. PCOS can get pregnant. Sometimes some of them do require IVF, and some of the resistant PCOS that we say do require a laparoscopic drilling or cauterization of the ovaries. So it's a myth that all PCOS are infertile. That's not true. PCOS do have an increased chance of miscarriages. So again, that of course you can't do anything about it. You just have to monitor the pregnancy and see what happens.
And Dr. Malpani, we had spoken about donor sperms. Now, the other thing is the donor eggs. Now, I have a same question that, what are the chances of pregnancy using a donor egg that has been frozen? Second is there any disadvantage compared to a fresh donor egg?
No, now donor eggs are always fresh. They were not always fresh in the sense you need to take them out of the donor. They're not fresh. Today we have technology where we can actually freeze the eggs and keep. And that is the common thing. In the past, we did not have the technology. So the donor cycles, you take out the eggs in the woman and immediately make an embryo and transfer. But today technology has changed. It's exactly the opposite. We never do fresh transfer. We take out the eggs, put them in the egg banks, store them. Once again, the donor is thoroughly checked for HIV, hepatitis, VDRL, medical history, hemoglobin, the routine tests are all done on them. And as long as you take a young donor, which means around 25, between the ages of 25 and 30, and with a proven fertility, if they've had children before, then we know that the success rate is going to be really high. So today we have women coming from the ages of 35 to 45 who want a baby. Now, it's very hard because the eggs, like I said, the egg quality deteriorates, the number of eggs deteriorates, so the embryo quality is very poor. So these are the women who try with their own eggs initially and then move to donor egg. So if with their own eggs, if somebody is, let's say, trying around the age of 37, 38, her success is just about 15, 20% or maybe less, sometimes even 10%. But with with donor eggs, the success jumps to 60%. Simply because the donors are young. And that is the trick. You need to choose young donors.
Got it. And, I have a question now related to men. There is a thing that goes on in the men's mind that excessive masturbation causes infertility or it lowers the sperm count. Is that a reality or is it a myth?
No, it's a total misconception, a total myth. Any number of times if you masturbate, it is not going to reduce the quality of the sperms or the motility or the number of sperms. So, of course, when men have infertility, they're always finding a reason. Why did it happen? I'm virile, my sex life is so good, I have a good beard, I have hair all over. And they're wondering why. Sometimes they're just blaming themselves, and this is an easy thing to blame, and they feel guilty about it. So there's no need to feel guilty. You can masturbate as many times as possible. Of course, what happens is if the ejaculate comes every single day, then the sperm count does go down a little here and there, but it's not true that it decreases the sperm count or the motility forever. So in fact, when we ask a man to give a sperm, before IVF or before treatments, or even when you're testing, we always say give a gap of 1 or 2 days, simply because the counts do go a little lower, not much. But that's if you want the right test, then you need abstinence for 3 days.
Right. And Dr. Malpani, a lot of young people today, compared to what we have seen about 2 decades ago, the average age at which people are getting diabetes or hypertension is lower. And do you think that these conditions like diabetes and hypertension are causing infertility in people today?
No. It has been proven that diabetes and hypertension do not cause infertility. They're nowhere related. They're not a cause. But yes, if a woman has diabetes and hypertension, then the pregnancy might have a problem, because those are the things. It's not, they do not they do not prevent you from getting pregnant, but once you're pregnant, there are problems in the pregnancy. So one has to monitor the pregnancy.
And Dr. Malpani, what are your views on surrogacy?
Okay. So surrogacy is actually just another assisted reproductive technique if it is used rightly for indicated cases, which are very few, then it's a very, very good option for those people who need it. Now, who are the people who need it? A person with an absent uterus. Let's say a person is born without a uterus. It is a rare condition called Rokitansky-Muller syndrome. One in maybe 50,000 people have it. Sometimes the uterus is removed due to because of a hysterectomy is done, maybe because of excessive bleeding or severe infections. For those people, it's good. Sometimes the uterus is damaged beyond repair. So for those people, it's a good option. Or the endometrium just doesn't become thick. But unfortunately, right now in our country, surrogacy has been misused, abused, overused. People are just looking at the celebrities and they say, oh, Shah Rukh Khan has done this, Amir Khan has done it. So even I want a baby. Today, young girls are coming to me saying, oh, I don't want to go through the pain of 9 months of having a child. I don't want the delivery pain. I don't want to spoil my figures. See, as long as it's controlled and it's done for the right reason, I think surrogacy is a very good option. I mean, there's nothing wrong about surrogacy.
And my last question to you, Dr. Malpani, is that what are some of the moral factors that every IVF practitioner must keep in mind when they're treating their patients?
Yeah, that's a good question because today, as you can see, IVF has got commercialized. Every gully, every nook and corner, every gynac, every doctor writes that infertility specialist. And infertility patients are very vulnerable, very gullible. And the lack of information actually causes them harm. People don't want to know much about their bodies or how babies are made, so the doctors are taking them for a ride. So I think it's a moral responsibility of every doctor is to educate the person first, give them the options, allow them to make informed decisions with the right information. And of course, I mean, basically not cheat them. I mean, that goes without saying. Do not overcharge them. Do not do the wrong IVF for the wrong reasons, which is being done today. So I think if all these basic rules and principles are followed, I think it's fantastic that India's success rate with assisted reproductive technology is on par with, USA, Europe, England, all over. I'm very proud about that fact.
Dr. Malpani, this has been such a brilliant conversation. Thank you so much for taking out time to, share your views and, clarifying the myths that people have around IVF. I'm sure with your experience and the number of firsts that you have done in your practice and the happy and joyous nature that I can sense from your face makes you, somebody who can really add value to any couple that is facing the challenge of fertility in their life. So thank you so much for your time.
Thank you. I really enjoyed this conversation too. Thank you so much.
Welcome to BW Healthcare World. Today is World IVF Day, and we are here to tell you about your IVF rights, what you can do, who can go for IVF procedures, who can go for surrogacy. We'll try and answer each and all of your questions with the experts we have on the panel today. We have with us Dr. Nitiz Murdia, who is the co-founder of Indira IVF. We also have a legal expert with Ms. Petal Chandhok. She is the partner at Trust Legal. Thank you, both of you, for joining us here on this special day. And we're very, excited to hear your views on IVF and its scope in India.
Sure. Thank you.
So let me begin with my first question, and I want to address it to Dr. Murdia. Dr. Murdia, tell us who can be a parent through IVF and surrogacy under the present laws in India.
Right. So there were two laws which were passed by the Parliament. One is the ART Act, and second is the Surrogacy Act. So when it comes to ART Act, all the procedure governs, which are the IUIs and the IVFs. They have defined the age. So the female age between 21 to 50 and the male age between 21 to 55 can undergo these procedures. Single females are also allowed to undergo these procedures. And the foreigners are also allowed to undergo procedures in India when it comes to IVF. Now let us come to the surrogacy. There is a bit of difference when it comes to surrogacy. So surrogacy has to be done with the female age 23 to 50, the male age 26 to 55. There is a bit of restriction in terms of single females who can avail surrogacy. It has to be, I mean, they have to be between the age of 35 to 45. One restriction that has come is that with surrogacy, you can't use donors. So when it comes to surrogacy, it has to be same gametes from the husband and the wife. But when it comes to a single woman, she can use donor sperms, but she has to be either a divorcee or a widow. This is the restriction that the law has put when it comes to ART and surrogacy, who can undergo, and foreigners are not allowed to undergo surrogacy in India. Indian origin couples only can undergo surrogacy in India.
Right. I when I was researching also, there were more questions than I could find answers, because of the legal jargon, because of the intricacies in between both laws, for ART and surrogacy. There's so much confusion. Miss Petal, I want to hear your views on the same, and with less technical and law jargon, if we can.
Right. So Shivam, so basically, so as rightly as Dr. Murdia said that we had these two laws that were introduced, in fact, in 2021 December, and the ART Act and the Surrogacy Act. And for all these years, we've been working in the field of ART, which is IVF, but we've not had any regulations, any laws per se. There were always guidelines. And there were self-regulated clinics. I mean, Indira has been working for so many years, and they were all self-regulated. So firstly, just to, give a background, that it was very important for the industry to be regulated. Also because it would help the patients, it would help even the donors, the surrogates also. So there were a lot of, we've seen in the past that there have been cases where donors and surrogates have been really, misused in a way, right? And somewhere even the patients have not had a very great experience. So now with the regulations in place, I think a lot of these, unregulated clinics who were there, so there's a lot of cleanup that has happened, and a lot of clinics have now, because the ones, who have great reputation, just like Indira, they have been able to really survive all these implementations of law. So all the, all the restrictions that we are seeing right now is actually for the betterment of the industry. That's one. Second, when we actually talk about who can take, let's understand surrogacy first. So primarily it has been restricted a lot. So earlier, how it used to happen before the act had come into place, that anyone could take surrogacy if they are able to normally prove that, they have a medical condition. In fact, even if they had a child, etc., they could take a surrogacy. And earlier, surrogacy was being done on a commercial arrangement. So all the surrogates who were there, they would basically be paid a compensation to become surrogates. Okay, and in fact, if you go way back, maybe 10 years back, these surrogates were never ever made to meet also the patients. So the patients actually did not know who the surrogates were, right? Just like donors are kept very anonymous. And this was primarily done in order to protect both parties, so that the surrogate should also not, somewhere take advantage of the parents, or the parents should not get emotionally attached. It was all very done in a very different understanding. But now they have completely put a ban and embargo on commercial surrogacy. So what the Act has now introduced is altruistic surrogacy, which means that I can only take, firstly, a surrogate, I can take a surrogacy service through someone who I know. Okay. So there needs to be probably, a friend or a relative or anybody who I know. That is the first condition. Second condition is that I cannot compensate that surrogate commercially, at least not in the legal, understanding. I cannot have a contractual arrangement with her to pay her anything, because this is being done completely on an altruistic basis and not commercially. So that is the second most important, introducing factor that came in this particular field. And the third one which came was that it's not easy now to take surrogacy, in India. You have to take a permission, that's a certificate from the National Board, Surrogacy Board, which I mean, sir is also part of. And only if you're able to get that clearance certificate that, okay, you really need surrogacy and, there is a very severe medical condition, then only you can, avail the surrogacy service. And I think somewhere it's very good. I was also part of the parliamentary meeting of the Rajya Sabha, which happened when we were discussing the surrogacy bill and the surrogacy act. And even though at that point in time, I felt, that it should not be altruistic and it should be commercial, because the moment it will be altruistic, it will lead to a lot of black marketing of surrogates, But now I really feel that with this change in law, it will actually help parents to also think wider and maybe turn towards adoption, which is also a very important aspect that needs to be looked at. Right. So that is about surrogacy, that who can take surrogacy in India. Of course, foreigners, sir has already explained, cannot take. Now, when we talk about IVF specifically, so we know the age that whoever can take IVF. Women, of course, can take IVF. A single woman who is above the age of 21. And of course, an intending couple can, of course, take IVF. Again, there is a medical condition, they can go, they can get a counseling done, and they can go ahead with the IVF procedure. So there is not many restrictions on the IVF front, but definitely on the surrogacy, we've seen a lot of changes that have come after the implementation of the act. So yeah, that's about it.
Right. Dr. Murdia, do you think these regulations, when we talk about surrogacy, that the donor, the surrogate has to be from known relatives of the family only? Do you think patients are also kind of, I mean, is it sitting all right with the patients? Are they finding hardships in that vis-a-vis the earlier when they used to find surrogates?
Yeah, I think it's a bit harsh for the patient, obviously, but I think the government thought process is to regulate this industry, because obviously there have been some cases reported here and there, and that is why these laws have come into place. I mean, this is not just something out of the blue. Something must have triggered government to come up with these acts and laws. When it comes to surrogate, I think the surrogacy law pretty much mimics the Organ Donation Act. And nowhere in the whole world, organ donation is considered commercial in nature, right? And which is the same way they want to apply the same principle on the surrogacy also. In terms of the patient perspective, I think a lot of patients have been going through surrogacy thinking that we have failed everywhere, or we have failed a few attempts, and we don't want to go through that trauma or torture anymore, and we want to go for a surrogacy, right? And there have been some where people don't want to get pregnant, they don't want to spoil the figure, and they have the money to afford a surrogate. I think all these practices which are happening, and India being thought as the womb country of the world, where you can just go and rent a womb and give birth to your child and take it out. So that whole image of the country being spoiled, and the Organ Donation Act successfully being implemented in India, I think, and a few cases, I think, which has triggered the government to think about this particular aspect of surrogacy and come up with a regulation to remove this commercial angle related to surrogacy and make it completely altruistic in nature.
Right. Let me come back to you, Mr. Chandhok. These IVF acts and ART Act and the Surrogacy Act can, with the help of these, specifically ART, can a single dad be a parent, or let's say unmarried couple, or a person from the LGBTQ community? With these regulations coming in, how is the outlook looking for them when they want to be a parent through ART?
Yeah. So, we have to understand that they are very new acts. They're just come. So, you can't expect everything from the government also at this stage. See, if we actually look at the provisions right now, the IVF services are only available for the couple, which is a legally married Indian origin couple. They have to be, of course, at the age above the age of 18 and 21, respectively, for a woman and a man. And for a single woman, it's available. It's mentioned in the provision that a single woman can avail the services of IVF. When it comes to single men and also any member of the LGBTQ community, particularly there is no such provision if you really look at the provisions of the Act. Of course, when you also look at the legal journey today, there are a lot of rights that the LGBTQ is also fighting for even today in the Supreme Court, and nothing has been finalized. Nothing has been actually given as on date. So they are also fighting for a legal marriage, which has a lot many implications. It results in, of course, I'm getting a bit away from current topic, but when you talk about a marriage, it will also eventually lead to conditions of, let's say, a matrimonial dispute. So all those conditions have to be looked into, and then only something like a surrogacy or a IVF service can be looked at as well. But currently, if you ask me, strictly as per the Act, as per the provision that we see, only a couple, a legally married couple, and a woman can avail the IVF services, and no one else has been mentioned.
Just to add to Petal, I think the inspiration has come from the Adoption Act. So if you see the Adoption Act, it says a male can only adopt a girl child. Cannot adopt a girl child. Yeah. So in a IVF process, sex selection is banned in India, right? I mean, not in IVF, but anyway, the sex selection is banned. So if you can't determine the sex of the child, there can be a possibility that a single man might have a girl child. So I think keeping that thought process or the Adoption Act in mind, they have not allowed a single male to undergo IVF treatment to give birth to a child. And it's only allowed for a married couple or a single female.
That's
right. But going forward, do you think these laws need molding, especially when we speak of the context of the LGBTQ community?
I think this particular thing has to come from the Supreme Court, as Petal also mentioned, because the ART Act will have to follow what is the law of the country, right? And as per the law of the country, what is now being recognized is a married couple, and it has taken the inference from what is the law of the country, and that is why it has allowed all the married couples to undergo IVF treatment. So obviously, I mean, whenever a law comes, there will be changes made, and I'm being a part of the national board of the expert members for the ART and the surrogacy law, and there have been a few changes which have been come up. There were problems being faced by the couples, by the clinics. There were technical issues with few things. It will keep evolving. I mean, we see that the PCPNDT law, which was passed to stop this sex selection and control these ultrasound clinics way back, I mean, 25 years back, is still going changes. So anything which comes up new will have teething issues, and will keep changing the law according to the conditions and the requirements.
Right. Ms. Chandhok, what are some of the rights of the donors that are in the gray area as of now?
So I feel that, like very rightly, Dr. Murdia said that there are teething issues that we have seen. In fact, when the acts were just implemented, there were a lot of clarifications that we had sought. I had personally written representations on behalf of many IVF clinics that I represent, and there were a lot of questions that we had. See, one of the most important factor, which I feel that is not very clear when it comes to donor. Of course, we know why. We know that this is a donation after all. I mean, if there's a donor giving a sperm or an oocyte, it's a donation. So the concept of compensation, will not be there. We understand that. Although now with the act, there is a very categorical provision that has been provided for medical insurance being provided for the donors. But how it has been happening earlier is that the donors used to be compensated, and that was primarily the reason as to why the donor would come up, and would actually be willing to donate, especially the oocyte donor, because the sperm donor will still not have any such procedure to go through. But when it comes to an oocyte donor, there is still a procedure that the woman goes through, and it's not very simple, I would say. Now, when we talk about that, I do feel that the right of the donor to sort of expect a compensation has been somewhere, affected, has been affected to a great extent. This is something that a donor cannot expect anymore. And the only thing that actually can be provided to them is medical insurance, and of course, any compensation in terms of anything that they have incurred as an expense. But beyond and above that, there's nothing that actually they will expect in return. They can expect in return. And with that, I feel that there is a major shift that has happened in the industry. Because it will be difficult to get hold of donors who would want to come without any financial compensation. And with that, of course, the patients are going to get affected, in return. So I feel that firstly is something that is there that really affects their right. Beyond that, I think secondly is confidentiality. Somewhere, earlier when we had the rules and regulations in place, we were very strict about keeping the anonymity of the donor, etc. Now it has become a little open-ended, because when I say that the patient has to get an insurance for a donor, then of course the patient somewhere knows the donor, right? He can either the clinic takes a call and says that no, we will get the insurance done, or the patient gets the insurance done themselves. And the patient can always get up and say that I don't want the clinic to do it, I'll do it myself. When that happens, then somewhere the identity of the donor is somewhere compromised, and that again takes us in that loop of being emotionally attached or being aware of who the donor is, and then the identity, of course, is somewhere which is very crucial here, and especially in now, of course, the industry has changed a lot, but if I go back a few years, there's still a taboo, when you would go for an IVF or a surrogacy treatment. So nobody and donors don't want to disclose, that we are doing this. So yeah, that is also one thing that I feel that that has affected the rights of the donors to some extent. But I feel that, as rightly pointed out, that there are teething issues. I'm sure these things will be looked into going forward, and we can expect some amendments maybe in the coming future.
Right, right. Uh, Dr. Murdia, I want to understand from you, when we talk about women donating their eggs, right? So, first of all, who can a woman donate her eggs to? And can a woman donate eggs more than once? And does a limited number of eggs being donated affect the chances of fertilization?
Right. So let me just add to what Petal said.
Mhm.
Let us look at what used to be the practice before the law and what has changed, when the law came, when it comes to donor, right? So before the law, there was no law that existed. The donor ecosystem, all this whole process was legal, illegal. There was no clarity on that, right?
Mhm.
So that time, how people used to practice was as per the guidelines which were issued by the ICMR. It
ICS.
wasn't a law, and that said that the donor has to be anonymous. Now it makes sense because there is no law in place. If the donor identity is disclosed, there can be legal challenges happening in the court, right? There can be cross claims, which has happened. But now the law clearly says, and there is a law in place which says that donation is allowed, and it says that once you donate, you relinquish your rights as a donor on the child, right? That becomes non-challengeable in the court, because once you donate, you can't have a right on the child, right? The second thing that has changed is earlier known donation was not allowed. But now, because they wanted to stop the commercialization of the donor and the surrogates, they have come up with the law which says known donation is allowed, right? So you can get your relatives, you can get your known people, you can get your friends, which was not, which cannot be there in the past because there was no law in place and the donor had a right over the child. But now with the law in place, they have to relinquish the right on the child. Hence, known donation is allowed. There is a difference between anonymity, which used to exist before the law. Now the law says that the clinic and the bank has to maintain the confidentiality of the donor, right? Which is a different term than anonymity. So yes, as Petal said, that while doing the insurance, they can know the name and the Aadhaar number of the donor. But again, in terms of the confidentiality, which has to be maintained on the part of the donor from the bank and on the part of the donor and the couple from the clinic, both are bound to maintain that, right? Second thing is, there were, as Peter also pointed out, that because of the changes in the law, the whole ecosystem of the donor has been affected. So before the law, I think anonymity was one of the criteria of the donor, and the donor had to be married, which was changed in this particular law, which talks about confidentiality and not anonymity. So known donors are allowed, and even unmarried donors are allowed now. So this thing has changed in the law. And what they have done differently in the law is protected, the safety aspect of the donors by asking clinics or the banks to have insurance in place which guarantees them compensation in case of death, which takes care of any health issues arising out of these donations for a period of 1 year, right? And they have also restricted in terms of the number of eggs to be retrieved when it comes to donor, which somehow tells the clinic not to overstimulate the donor, because overstimulation or putting more number of higher dose of injection can cause health issues to the donor, and even which in medical term we call as OHSS, or ovarian hyperstimulation, which can be detrimental to the health of the donor, or even there can be higher risk associated with the donor. So they have tried to restrict clinics in terms of how they use the donors, how much injections they put on the donors, what is the dosage on the injections they put, so that this whole process becomes more safe, in terms of donor. So I think this 3-4 things the law has brought in good in terms of the practice that the clinics would have to adopt, and the safety of the donors. They have also introduced banks, which never used to exist before the law. So now there is a body, or there is a bank which is responsible for screening, data record, maintenance of all these donors, which is separate to the clinic. So all the responsibility and the reporting of these donors has to be done and taken care by these banks. Clinic will have to report their data separately to the national registry, and the banks will have to report their data separately to the national registry.
Right. Now about the number of eggs that women can donate, and that can the limited number of eggs being donated affect the chances of fertilization, which I saw some doctors point out. Is there any sense to it?
Yeah. So when we started discussing, in the national board, the first meeting, we have highlighted this thing to the government that, for a clinician, it is not possible to define a single number of the number of follicles being formed. And this 7 number, which was defined in the act, is something which is very difficult for a clinician to restrict, because when you give injections to a female, the number of follicles that will grow will depend on the female. Some female might have lower number of eggs or follicles. It may grow lower number of eggs and follicles. Some female who have higher number of eggs and follicles may grow more than 7. So it is not possible for a clinician to control the number of eggs, and hence they realized this thing, and they came up with a notification later on saying that all formed follicles has to be retrieved, right? So I mean, they are open to making changes. It has to be practical, it has to be feasible, and of course there has to be a long learning which will go in the coming years, and whatever changes has to be done in the benefit of the patient and the safety of the patient.
Right. And also, a woman, we see with the IVF that there are, only a limited percentage of chance of a person becoming a parent. So, there are people who try, number of times. But in the law, it states that a woman can donate her eggs only once. So explain that.
Yeah, so what they have come up with, again, this is again related to the safety of the donor, which I missed earlier. So when it comes to male, what they have said in the law is that one donor, one recipient couple or female, means a donor can only donate to a single couple.
Mm-hmm.
When it comes to number of donation they can do in their lifetime, they have restricted the female donor to only one donation in their lifetime, and that one donation, which is the number of eggs she donates, has to go on a single commissioning couple to be used on a single commissioning couple. You cannot divide the eggs into two couples or a single woman or a different couple, right? You cannot do that. It has to be one donation going to a single couple. But when it comes to male, right, they don't have any health risk considering the donation that they do, and hence a male can donate multiple times in their lifetime, but the sample or the semen sample or the donation has to be again used for a single commissioning couple. They cannot use it on multiple couples.
Okay, right. So, in a case, if a couple is trying to again try for an IVF, they'll have to find a different donor.
So when it comes to if they're requiring a male donor, they have an option to use the same donor, or they have an option to use the second donor.
Mm-hmm.
But when it comes to female, because the female has donated once and they've used the eggs, in case if they fail, they will have to use another donor.
Right. So when we talk about the number of follicles, and you told about that there are some changes which have been made, that the doctors, the clinicians can now accordingly perform the procedures. If there is a women they think that will produce less follicles, they'll put in the injection would be of higher dose that you were talking about. So those changes have come at this point in time.
See, the government does not want to get into the clinical aspect because they think doctors are the best to handle. What they can do is come up with regulations which would be safe for a donor and a surrogate, right? Which they have already come up with. And in terms of the clinic practicing which treatment protocol they want to use, it depends on the doctor's purview, because we understand that with time, science and technology will evolve. The protocols will change, the injections will change, the pharma thing will change, and the law cannot change again and again, right? So the law only will talk about restrictions in terms of the safety and the commercialization.
Absolutely.
But it will not go into the medical treatment part.
So clinicians clearly have that freedom at this point in time. And when you talk about that number 7, do you think that is suffice for fertilization, like clinically speaking?
So the number 7 is a very, I would say, there is no definition or there is no rule, because the number of follicles that you see in the ultrasound, when you do ultrasound for a female, when you take the follicles out, you lose something. Let's say if you start with 10 follicles, you might retrieve 10 eggs, right?
Mm-hmm.
And out of those eggs, there may be 7 eggs which are matured eggs, 3 eggs which are immature eggs which cannot be used. When you fertilize those 7 eggs with the sperm and you try to form the embryos, there may be a situation where 3 to 5 embryos are formed, which is after 3 days, there may be 3 to 5 embryos are formed. And normally these days clinic go up to a blastocyst culture, which is culturing the embryo for a 5-day period outside in the lab, right? So when you have 3 to 5 embryos, there may be a possibility of 1 to 3 blastocysts being formed. And then normally when the clinics transfer as per the law, they can transfer 1 to 2 blastocysts or 1 to 2 embryos in the couple. So ideally, when you are doing this procedure, you may require higher number of eggs than 7 to reach up to a optimum level of 2 blastocysts being formed for transfer to happen. But this rule will not apply everywhere. There may be couples who might have less number of follicles being formed, and even if they are, even then they are able to form two embryos to transfer. And there may be a situation when 15 eggs are retrieved, but two embryos are not formed. So it again depends, but I think the optimal number is somewhere between 7 to 10, and this is only concerning the donor. Let me tell you, this is not related to when a patient undergoes IVF cycle. There is no restriction on the number of eggs being retrieved. This is just made for the safety of the donor, so that the clinics don't overdose the donor to cause a health risk on the donor.
Right. Ms. Chandhok, when we look at the ART and surrogacy bills as a whole at this point in time, with all the suggestions or a little bit of criticism that it has received when it came, what are the improvements as a legal expert that you would suggest in the current law?
So the improvements that we can suggest going forward, that's what you're
Yeah.
saying. So as such, I feel that there is no such improvement per se that we are looking at. Of course, as we are going to implement the law, as we are going to implement the provisions in the ground, etc. We will see that there may be certain things which needs further clarification or which needs further amendments per se. Uh, uh, Maybe that does not mean that the current provisions are not correct or they are incorrect, etc. But sometimes what happens is, and we've seen it with practically every law. We talk about arbitration, we talk about any law which are old laws of 20, 30 years, which are still being implemented because the way that a provision is interpreted is different for every lawyer. So we can interpret the same provision in a different way, and it can be interpreted in a different way by somebody else. So for example, if we pick up a provision, let's say in the ART Act, we may interpret it in a way which suits our clients' requirements best. But it can be interpreted another way by another client or etc. So when we talk about those things, somewhere the requirement for clarification, the requirement for, let's say, we see a lot of provisos or provisions that come in every act, those are basically clarifications that are introduced in every act, in every law, as and when they are implemented. So even in this, it's just been barely a year that it's been implemented. In fact, in 21, it was enacted, and it gave 6 months window to all the clinics, etc., to apply for registration, etc. So it actually was made effective only in April, etc. And even after that, it's just barely been a year. So we have definitely seen a lot of provisions where we had sought for clarifications, we had sought for further understanding as to whether it can be used in this way or that way. And of course, one teething issue that we also found was the implementation of the boards, like the implementation of having the state boards or in place so that registrations could be done. In fact, a few months till a few months back, a lot of clinics were facing this difficulty of applying for registration and then payment for registration. So very small things, of course, plays an important role for that particular business because it's their bread and butter. But these are very basic. These are not something that we'll say are incorrect or something that needs a very vast change. I think these are more or less very basic in nature. And as and when this is more further implemented by other players in the industry, we'll see the need for certain amendments, which are not very significant in nature, but very minor. And I think with that, it will keep happening. It's not something that, it will stop after a year. I think as and when the times will change, just like the male aspect and the LGBTQ community, all of these, amendments we will see in the coming future to be introduced. So yeah, that's what my understanding is. Of course, Dr. Murdia would want to add on to that, but yes.
Right, right. Thank you so much, both of you, for joining us here on the World IVF Day. I think a lot of questions that viewers had, they might have got answers to that. And as you said, Ms. Chandhok, there are some clarifications, so to say, such where uh, for any person, for a journalist, for any person, these clarifications are needed as to how they are in the end interpreted, and there are no confusions to the law. On that note, thank you so much once again. Thank you for joining us here on BW Healthcare World. It's been a pleasure hosting you.
Thank
Thank
you.
you so much for organizing.
Welcome to the World IVF Day. We've seen the industry grow, and the need for the industry to grow is because the need for fertility treatment is growing. To understand what IVF is, what it does, and what could be the possible causes, we have a panel of esteemed doctors who are with us today. Let me introduce the panel today. We have Dr. Sameer Malhotra, who's the Director and Head of Department for Mental Health and Behavioral Sciences at the Max Multi-Speciality Center at Panjshir Park in New Delhi. Joining us is also Professor Dr. Jaideep Malhotra, who's the MD, and she leads the ART at the Rainbow IVF Center. Dr. M. Gouri Devi, who's the Director and HOD of IVF at the Fortis Hospital, Shalimar, Bagh, New Delhi. And last but not the least, we have Dr. Madhumathi Ramakrishnan, Senior VP Claims at Star Health Insurance. She herself is a medical doctor who's helping the insurance side of the business today. So I think it's going to be a very, very useful conversation for anyone who's watching this today. Thank you so much, all the panelists, for joining us today.
Thank you.
My first question is to Dr. Gouri Devi. Dr. Gouri, whenever we have a couple coming in for a consultation for fertility treatment, what are the common basic questions they have for the first few sessions? What are the things, doubts that they're dealing with?
Okay, those patients who come depends upon how many years of infertility. Some may be coming the first time ever for a consultation. For them, it is basic consultation that why am I not getting pregnant? I've been trying for 1 year, 2 years, whatever. There are some who comes from where they've taken already a lot of medical treatment and they've not been able to conceive. So they will come to us asking, I have taken so much of treatment, it still hasn't happened to us. Why so? Then the third category are the people who have already had ART, it is failing, then their questions are different. Why is it not working for us? So the questions will vary according to what the patient is. But general questions, since it's a World IVF Day, in IVF, what they ask us, doctor, is it a very painful thing? We are told that a lot of injections are going to be taken. And we are told that we have to rest for 9 months. And is it very expensive? These are some of the basic questions they ask when they come for IVF. And how successful is the procedure?
Right. Thank you, Dr. Gouri. Professor Jaideep, when we talk of the aspect of stress, one is that stress could be causing fertility, but the other is people are stressed because of infertility. So if we talk about this, what are some of the stress points that you see while consulting about assisted methods of pregnancy? What are the kind of stresses that you see in their faces, see in their conversations when they come to you?
It's really important for us to understand that there are so many stressors in their minds. And the first consultation when they come to me, I'm looking at various aspects, right from with whom they have come. Like sometimes, they'll come with a husband and wife will come, but many a times a whole family comes, one from the side of the boy and the other from the side of the girl. And then once the conversation starts, along the conversation, I'm looking at a lot of aspects because it's important for me. Because tomorrow, when I have to give them a kind of, direction to their journey, I need to know who are the contributors which are there. One of the major important aspects, which probably is the first one, which comes into their mind, is the finances. And second important is the results. Like, half of the people think, okay, once they'll go through IVF, 100%, they will get a pregnancy, which is not true. And, and the family also doesn't understand. Then the performance. Supposing if husband has, some low sperm count, or the wife's age is a little higher, then the issues and the stress about their performance during the procedure is also something which really stresses them. And another very important, I have seen 40 years now into practice, I've seen families crumbling down because we have joint businesses. Now, if one brother has a problem, the money has to come out from the joint business. And I've seen them crumbling down, divisions happening. Now, who's going to understand and finance and fund something? There are multiple things which happen at the family's level. And then their understanding about the procedure, which is again very important, and the outcomes, plus how resilient they are going to be in the procedure itself. Because this is something which, and then interpersonal relationships, because half of the time they are blaming each other, because of you I did not have a child, or because of your time factors or your career. Every strata has different stress factors. And the biggest probably one is the fear of failure, which is another very important aspect. So the conversation is normal, but in my mind, I'm noting down a lot of things which help me in counseling them at a later stage.
Fantastic. I think this is some of the points that you brought up are very different. I mean, I usually did not think about it when I was thinking of stress. Dr. Samir, when we talk about stress, there are two aspects. Like I said earlier, do you think first that stress could be one of the causes of infertility?
Absolutely. Absolutely well said. It's a two-way link. So it's the stress which leads to changes in your hormonal profile and the neuroendocrine system, which can negatively impact your outcomes in terms of fertility. And because of not being able to produce a child, that also leads to a lot of stress and stigma. Now, in the society, if you look at the situation, many a times people have this concept and the notion that a woman is less of a woman if she's not able to bear a child, or she's incomplete. And similarly, for a man, he's less of a man if he's not able to father a child. Now, in those kind of concepts, there is an added pressure to have a child of their own. And the second thing is this understanding, within the dynamics of the family, that today we are looking after our children, and tomorrow when we grow old, our children would be able to take care of us. So that kind of a model, which is there in the eastern part of the world by and large. So with those kind of things in their mind, if they are not able to conceive a child, that creates a problem, and that creates added stress. And because of that added stress and the underlying neurochemical disturbances and the neurochemical disturbances, at times they are not able to conceive. And then, like Dr. Jaideep also pointed out, there's a lot of blame, which happens amongst the couple, or maybe one side of the family blaming the other side, wherein they feel that because of maybe career choices or because of certain reasons attributable to one partner, the couple was not able to conceive in time. So when all that gets added on, so there is an added guilt, there's an added shame, there's added social pressure. All this adds on to the stress. Plus, their inadequate knowledge about the IVF process. And like the doctors here in the panel said, that they're not very sure as to how this is going to proceed. And this process in itself can be cumbersome for some. And if they're expecting 100% results, a lot of stress can also interfere with that result outcome. There are studies to suggest that if the patient is quite stressed at the time when they're going through this process of IVF, then the outcome is also not as good as compared to what it could have been if they were less stressed. And the persons who show a good kind of outcome are the ones who are relatively less stressed. And that has been measured biologically also through blood cortisol levels, through blood norepinephrine levels in those females.
Dr. Jaideep, I know you're raising hand, but I would also want to ask you that do you think that the practice of IVF and gynecology today needs to be clubbed and work very closely with psychology?
Yes, 100%. That's exactly what I wanted to point out when I was raising my finger. Because, today the couples, especially young career-oriented couples, have totally mechanized reproduction. So they feel, okay, I'm going to take out 2 days out of months, whatever work I'm doing, and it should happen at that time. And it so happens that people have, performance issues. Like if somebody, the wife comes and asks me, you tell me the ovulation day, my husband is going to take leave and come. Now, the husband takes leave and comes, but is unable to perform. Erectile dysfunctions and non-performance issues are so much. Even when we are doing IVF also, I always keep a backup sample, because on the day of the pickup, so many times it happens that the husband is unable to give a sample of semen, and we will not be able to go ahead with the procedure. So I always keep a sample, and this is what stress does to you. As far as results of IVF are concerned and stress is concerned, I think before that we must handle that stress. They should not reach that stage where the stress is mounted so much that they're going into a procedure now, because that is something which will lead to many failures later on. Though I would say that science and there's a lot of evidence which says, okay, on the day of the IVF, the stress and the results do not really matter. But there's so much before that which is happening, which is definitely going to lead to major problems.
Right, very well said. Dr. Gouri Devi, you want to add something?
Yeah, I was telling many of the big IVF centers now has made yoga a part of this thing. They are doing the counseling. And in our setup, we right at the beginning of the IVF cycle, we give one session of counseling. Mm-hmm. Then, the hell breaks through when it fails. See, the woman, once the embryo is installed, she thinks there is a baby inside my womb. Mm-hmm. Now, it doesn't work out. It has failed. And then she starts, she's very, very upset. That time also we have a counseling session by a counselor, so that, she shouldn't feel that there is no other. As Dr. Jaideep correctly said, they feel that once you put in an embryo, 100% it's going to happen. We counsel them. It's only 40% maximum in a cumulative 60%. It's never 100%. Right. So yoga, many people take it as a part. One thing we found was when they're very apprehensive during embryo transfer, because we do it without anesthesia. So what we do is we tell them, do you listen to any bhajan, and will you listen to any kirtan? And we put that on, and they cool down. For transfer, it is easy. So such things definitely helps.
What I hear is that that the healthcare system of today, especially the gynecologists and IVF, acknowledge the fact that stress is something that needs to be managed. And I'm so glad to know that there are centers which are not just acknowledging it, but taking steps like bhajan, yoga, etc., to go beyond the basic procedure of IVF. That's a very beautiful thing. But since we brought up the issue of the stress around who is to be blamed for, this is natural, something that has happened to the body, but our social stigma around infertility, even though it is becoming better, but it is still there. Now, what I really want to know, Dr. Gouri, from you is, what are the usual tests to know what could be the cause of infertility, both in the case of men and women?
Yeah, you see, what we do is, coming to the men, basic thing is a basic semen analysis. And in that, if there is a problem, there is a less of count, or the abnormal sperms are more, motility is more, then we have some other tests like, Y segment, we do fragmentation. Sometimes we have to do karyotyping. Some certain things are there in the men. In the woman, basically, we have to do some of the blood tests and tube test, whether the tubes are patent or not. Second, third is the uterus fine? The uterus is healthy when we are doing a transfer. Is it healthy? Is it there is some procedure we have to do to correct it? That is the and of course the routine blood tests we do. And advanced tests, there are many. Maybe this is not the forum where I'll enumerate all the advanced tests. And once the tube test is, sometimes when we take out the biopsy, tube test, they are very apprehensive. Patient is very apprehensive because they read the net. And in Google, it is written, it is very painful. So we have to really counsel them, no, it's not a painful procedure. We'll make it as simple as possible, like that. Once, in India, tuberculosis is a very common problem. So once in a way, we have to take out a biopsy to make sure she doesn't have it. So even for that, she's very apprehensive. Number one, is it painful? Then as Jaideep said, the family will say, no, we don't want to take out anything from inside. So we have to counsel them. We have to do the test. So these are things we face day to day. We face these things.
Got it. Before I come to Dr. Madhumathi, I have one question, Dr. Sameer, for you. Since we are talking of stress and we are talking of, that infertility could be not just the woman, but also for the man, because of the man, But now the blame game happens and suddenly, there are conversations that move around that, you drink because of which now we are facing a problem. You are traveling so much for work because of which now we are facing a problem. The blame game is not just about a woman, it is for the man as well. How do you recommend these stresses can be managed or best managed by the couple once they know the cause of infertility?
I think it's very important, very pertinent question that you've raised. Like Dr. Jaideep also said, when the first time the couple is approaching them, it's a lot to do with their kind of interaction and the way they are interacting with each other, the way the other family members are interacting with them. So you get to know the family dynamics as such. You get to know their attribution styles. You get to know the blame game also to some extent. And I think you also get to know an obvious level of stress which is there within that family setup. I think that's a very good starting point. When you observe these things, speaking to them individually becomes very important. Making them understand how important it is to remain stress-free and not to attribute all these positive factors to the other person all the time, to improve this heightened sense of expressed emotion, which is not very good in any family, because it leads to melodrama at home also. And in that negative environment, nothing positive comes out of it. So starting point should be that point when you are able to observe those kind of dynamics, gently probe into, gently cajole, gently tell them, see, this is something that we need to work on. And that's when the role of psychiatrist, psychology steps in, wherein we can identify issues like underlying substance misuse or alcohol misuse, which can also impact fertility to some extent. Those are things which can be treated, right? There are certain things which can be treated biologically. There are certain things which need to be treated through interaction, through counseling. And I think those both things together in tandem are going to work in the couple's favor. Wherein, because it's a process, the couple have to be together in this process. We have to take them through this process. It's not just the couple, it's the doctor also involved. They also go through those highs and lows, with the patient. So I think it's a journey where all of us have to make sure that we are all in tandem, we are all in sync with each other, we understand each other. Let's not blame each other for whatever negative is happening. Let's try to sort it out and create a positive outcome and a win-win situation.
Right. I think what you've really brought out is a very important aspect, that this treatment or procedure, specifically, the outcome would depend on team management. I mean, it's the patient, the partner, the family at home, immediate family, the parents, the in-laws, along with the doctor. So the whole team has to work together, and even one link out of the chain, if it moves out or does not work well, can spoil the outcome. Very beautifully brought out, Dr. Sameer. Dr. Madhumathi, let me come to you. One of the things that we've heard from each of the three doctors related to IVF is that one cause of stress is finances. And so one is ki expensive hai. Second is, while I'm willing to spend money, we don't know the outcome is going to be successful or not. At least this particular cycle could be successful or not. Third is that what I heard for the first time is that we sometimes do not understand that the finances could be creating stress in your back end, your business. Who's going to spend money? What are the other brothers or sisters thinking about it? Where's the money going to go? So, which makes a point that financing this procedure becomes really important. How is insurance evolving to accept IVF treatment as a part of something that insurance should be funding? Is there still some reluctance in adding IVF as an essential process to be covered under insurance? And if it is, what could be the reasons for this reluctance?
So at the outset, I would like to say that insurance is also now coming forward to be part of the team, which you were talking about in managing infertility. It is not like before. So we are evolving. But before that, I would like to say that definitely, one of the most important reasons for stress-induced medical conditions or disorders is financial issues suffered by the patients. So, of course, the cost of good healthcare is very much prohibitive, as you may know. And this is definitely a reason for everybody to positively consider purchasing a health insurance policy. So in India, for example, not like the Western world, in India, majority of the healthcare expenditure is from out of the pocket. So it is slowly crawling into double digits. The people purchasing health insurance and the penetration of health insurance in India. Now, having said that, medicine is evolving. Evidence-based medicine in the field of infertility is evolving. Insurance is also evolving over a period of time. We want to work in tandem with the medical experts who are available here. And this coverage for infertility is definitely a paradigm shift and the need of the hour as far as health insurance goes. But now, medical professionals like me are involved in providing insights to our product and actuarial department. So the appetite for covering a risk increases and we want to innovate more and more. And our insurance regulator is very encouraging in these out-of-the-box ideas and entering into areas which we have, hitherto not entered. But the challenges we have are now with the availability of accepted treatment protocols, lot of technomedical advancements happening in the field, increased awareness, trained medical professionals, recognized centers. I'm sure there are some standard bodies recognizing these infertility centers for treatment. So all these added together, and also documented data in terms of outcomes. So earlier we did not have that much of a documented data. So now there is a lot of documented data in terms of outcomes. All these put together has emboldened us. We have become bold, to feel that, yes, our appetite has increased and we want to expand our coverage in these kind of areas that have otherwise not been ventured into. Also, this out of all the steps, the senior doctors were mentioning about diagnostic tests. Then you have fertility injections. Then you have the ART. The ART part is the most cost prohibitive part, most expensive part. So that is where, at least in Star, we have come forward in the retail segment to cover this, particular treatment because we understand that, there is a lot of challenge the couple faces together in terms of going through the entire process. That's why I said at the outset, we also want to be part of the team treating the patient as well as our customer. Last but not the least, it's still baby steps. We have a long way to go for this to be included across all policies as a regular or a comprehensive health coverage. But we would urge more established centers coming forward to this kind of treatment. At the same time, more young women in the reproductive age group taking the product so that the cost of the treatment, the premiums, they become more affordable, as well as the accessibility to healthcare improves. The more the established centers, the more the accessibility, the more young women taking the policy, the more the affordability. So our we are a law of large numbers, so we want this to happen as soon as possible.
Dr. Jaideep, okay, what is it that you want to speak about this?
One thing which I wanted to tell Madhumathi was in our country, our age of menopause is much lower than the Western world. Like it's 51 in the Western world, ours is 46.5. Now, when we say young, what is our definition of young? Now, there's a huge problem here because we have seen that premature ovarian insufficiency is very common. Like in the world, it is like 1%. In our country, it is 4 to 5%. So young women, who I would say, like when the Western world says cutoff is 35, I feel in our countries, the cutoff is less than 33. And I have a whole lot of young women who are coming in their early 30s who have hardly any ovarian reserve and they come for fertility preservation. So we need to make policies which will actually, benefit them for fertility preservation, not only because they are not, so many of them are not married at that age. So I feel, and plus, I'm sure you're going to ask me that question again about the pull-off period and all. It doesn't hold true for our country. So we need to evolve policies and the schemes which are actually customized for our own population, and then following the West. And there are many other things which we can do. Maybe we'll discuss them a little later, because lifestyle is again one of the major problems in our country. Absolutely. So we can have insurance based on the lifestyle. Okay, 3 months, 4 months, optimize your parameters. Then we will think about, there's so many things we can do.
Dr. Gouri, you wanted to say something?
Just one point. The problem in India is infertility is not recognized as a disease. See, generally, if the government recognizes as a disease, it may be easier for the insurance people to give. You see the general policies. Nobody covers it. Start to some extent. Tata consultancies to some extent. Some of the government or semi-government setup like CGHS gives for the drugs, or ONGC, they almost completely, railways cover 25%. So it's all different. So if the infertility can be recognized as a disease in some of the countries, they are. In India, it is not. For us, population is the problem. See, once it is done, it will be easy for the insurance.
Right. And
Gauri, but I just wanted to say, because I was in the terminology group of WHO, we took 6 years to add one line. Infertility is a disease.
Yeah.
And it is there now for a long time. But our country needs to recognize.
India doesn't recognize it.
Got it. Dr. Gouri, this is a very pointed question in terms of women at times post-diagnosis are asked to go through laparoscopy for opening their fallopian tubes. Now, is it a safe option? What are the complications associated to laparoscopy during pregnancy or even post that?
Usually during pregnancy, we don't do laparoscopy unless there's an indication like an ovarian cyst in the early months of pregnancy. Yeah, for tubal block, if it is in a certain conditions, like in a tuberculosis, we don't do a laparoscopy. But if it is other minor tubal block is there, it is a good way for, if you open it up, the tubes are open, it is for the lifetime for the patient, right? She can conceive again and again. Blocked tubes, both sides, means she has to come to us for IVF every time. It is not an unsafe procedure, let me tell you. Laparoscopy is practiced all over India by many, many centers. Second tier, even third tier cities have good setup to do laparoscopy. So when indicated, I don't think we should cover. Now, again, there is a problem. You write the word infertility, for which I have done. See, there are conditions like endometriosis, where we are forced to do. There is an abscess in the ovary, or it's the infected ovary. We have to do it. And if I write endometriosis, it's a disease, the insurance covers it. But if the infertility word comes anywhere, insurance take their hands off.
So, Dr. Madhumathi, let me come to you then. Why are the surgeries or surgical tests not covered under insurance? Unless I am mistaken on that.
No, see, it's like this. See, if there is a therapeutic treatment followed by a laparoscopy, for example, you take a tubal block, there is a therapeutic treatment followed by a laparoscopy, then we do evaluate it on a case-to-case basis and we consider the claims. But the concern that we have is some of the unrecognized centers, if I may call, not so certified centers, and not so skilled professionals. There is some lack of transparency where they may not prescribe the standard treatment protocol that is required. So that is where our concern as insurers comes. See, I have worked in hospitals for so many years. Now I'm working in insurance for so many years. I've seen both side aspects. We're not talking about skilled professionals or certified centers here. We're talking about certain elements where there is some lack of transparency. Here, we are slightly skeptical about providing that coverage, which is right as well, because we have to be very careful about those elements as well.
But Dr. Madhumathi, you write the word infertility. It's gone. The patient doesn't get the money. Am I right? Am I right?
As I said, see, we are evolving. There is definitely baby steps taken in this regard. We have started to cover infertility in one of the retail products. In fact, I'm talking on behalf of industry, but if I have to talk on behalf of Star, I may just take a second. We have a woman-centric policy. When I said young reproductive age group from the age of 18, it is it is catering mainly to women and offering a whole range of benefits to young women starting from their reproductive age group. And this is all inclusive cover, right from antenatal care to prenatal care to to ART, infertility treatment, to in utero fetal surgeries, to the baby neonatal care when the baby is born, congenital internal defects, external defects, which have hitherto never been covered in the industry, as well as vaccination, metabolic screening, etc., etc. There's a whole range of benefits. But as you were earlier telling, a lot of awareness has to happen. So a lot of campaigns has to happen. Insurance probably has to join hands with, Federation of FOGSI, obstetricians and gynecologists, to promote this in a big way, so that more people take the cover to be benefited.
We did have a meeting with the Federation regarding IVF. They were not with.
I just want to point out one thing, Madhumathi, because that's something which I feel very uncomfortable about, because a couple will come and is an infertile couple, they need laparoscopy, and when I say laparoscopy, they say, madam koi or indication likh dijiye, infertility nahi likhiye. No, where is the transparency here? Because I lose out on so many patients because I refuse to do that. And I feel that I'm being forced to write something which I don't want to, because it is truth. And then when you're looking at an insurance coverage, you're covering it for the disease. And this disease is leading to infertility. So where is the problem? I mean, this is something which I don't understand. And why should I tell a lie?
I think, to
help the couple, which I so want to do.
Yeah, this is a very valid point that, sometimes infertility could be an outcome of some other disease, and it is not infertility per se, but it is an outcome because of something else. But I think this is a debate that can go on. Dr. Jaideep, you very strongly came out about the stress around the finances. So my question to you is that while the IVF process does not guarantee success in its first go, how do you counsel the couples that they may need to go through multiple attempts?
That is my first counseling, which actually happens, because I also know heart of hearts, not all of them are going to have a baby in the first go. So, and if I do not do this in the first consultation itself, it will leave a lot of bad taste in their understanding. And also, for them to get up and then start another cycle is going to be even more difficult. So after, assessment of the couple, whether it's mental, physical, and, the reproductive, the counseling starts from there. Like supposing that a young couple comes. I know the ovarian reserve is good. We will probably have some good embryos for freezing. So the financial counseling starts there. Okay, be ready mentally. We normally say for 3 to 4 attempts, because we understand about 80% of the couples will go back with a baby in 3 to 4 attempts. But again, there is always a caveat. We'll do the first cycle, because I always tell them it's not only based on me. I'm going to make embryos of the gametes which you will give. Like if supposing somebody 110 kilos is in front of me with a bad, poor lifestyle, I know the gametes are not going to be as good, or with a PCOS, androgenic. So we counsel them accordingly. Because finances is important, but understanding for the failure is equally important. And I also tell them that it equally affects us. It's not only them. For me also to get up and say a negative test. So for my preparation starts from the first consultation, that be ready. You will go to success bypassing the failure. So you always will see failure when you go for success, and that's something which we should be looking at. Plus, it is about implantation. I know 99% I will be able to make embryos. Very few times you will fail actually in the lab. But maximum failure happens when once we implant the embryos into the uterine cavity. And endometrium is one of the biggest factors. So all that counseling, it takes a little time, but is done in the first or the second session itself, so that they're ready for a second try. And it also depends on the age, because and most of them come at a elderly age group, like they'll be, in their mid 30s when they start coming. And we, as I have already told you, their reserves and everything else is going down in a steep way. So if I don't counsel them at that point, then they might take a little longer time to come back for the second cycle. And I would counsel them accordingly, so that, they are on a journey in the next 6 months to 1 year to achieve a pregnancy and take a baby home. So that's how my counseling goes. And I just wanted to tell you that I've made a lot of films. So I've made one film, Main Banj Nahi Hoon, and it runs in my clinic all the time to make them understand a lot of things, how to choose a fertility clinic. So these films run in my waiting room so that they are mentally prepared and geared up. In fact, there is an app which is Pradhan Mantri's Atmanirbhar app, challenge winning app, which I have made, iMums. It's again about the pregnancy journey. And we are now adding preconception. So the holistic way towards achieving pregnancy is also very, very important.
No, I think it's very important because, when we started the conversation, you had mentioned that when people come in from the first attempt, they think that 100% ab to ho jayega. So managing their expectation itself is a big task and a responsibility of a treating doctor. And second thing that you mentioned, that it is a journey, and it is important to let them know that abhi to, this is a journey on which you have to continue consciously being on until the success happens. Dr. Samir, since we are talking of stress, and what Dr. Jaideep also mentioned, that the stress is not just on the patient. The stress is also with the doctor, because they're also ki, हमने कोशिश करी नहीं हुआ, या I don't know, because unpredictability is the core fundamental of this treatment. And even the doctor is not sure whether it's going to work out or not work out. So how do you suggest doctors deal with failures with their patients so that they appear hopeful, they appear happy? Because, kai bari when we visit a doctor, the doctor's words and doctor's expressions could be there could be a dichotomy in that. So how do you suggest doctors need to keep their faith in the system?
You asked a very difficult question, a very complex one. There's no easy answer to it. But I think as doctors, we are trained to empathize. A part of empathy also comes through our personality profile, isn't it? So every doctor is a little different in terms of one's personality, like all of us are different. It's also the choice of words and the way we express, and a lot of expression and communication happens through body language. Before that, a lot also depends on what we are thinking, because it's mansa vachana karmana, isn't it? What you think is what you project, isn't it? So if you have a calm demeanor yourself as a doctor, if you are taking them alongside this journey where they understand that you're also part and parcel of it, it's not that you are just the provider. You are also equally involved. Like the doctors here also said on the panel that they also feel bad, when the outcome isn't coming as good as expected. So it's about realistic expectations. It's about being prepared for that failure. It's also still instilling that sense of hope, which is very important to achieve a positive outcome. It's parallelly working on the family dynamics. It's also working on oneself as a doctor through this process, through this journey. I think it's basically how to deal with failures and how to keep this hope and patience alive that we are talking about. A lot depends on techniques like yoga, meditation, like Dr. Gauri Devi also suggested. But alongside, I think it's your positive self dialogue. It's the calm demeanor. It's the positivity that flows in that dialogue, in that conversation. And I think wherever we feel that this particular patient or this couple is going through a lot of stress, at times they have prior diagnosis of a psychiatric illness also. So it could be that the wife was depressed and that is the reason why she couldn't conceive. Depression could also be a factor. It could be that the husband went through depression and that's the reason why the quality of sperm isn't very good. So they need that kind of right treatment, identification in time, involving them in the process, so that in that journey we create a win-win situation wherein the doctor is also relatively stress-free and the patient and the couple as such is also relatively stress-free.
Got it. And
I want to tell you how I would like to, I normally do it. And I tell them like, the journey is yours, but I am a Krishna here. I'm your Sarthi here. So I'm sitting in the same Rath as you. And we'll together try and sort it out in the best possible way. But I do not ensure a victory, but I can tell you that even in your failure, I'm there with you. So that is something which, it does generate a lot of confidence in the patient. And of course, the pains are equally felt by each one of us doctors also. And I share my experiences that I also feel very bad if some week, the results are not very good. I normally go to, I do meditation and yoga, but I also go to an institute called Mana Shakti, which, in Pune, where we also interact with each other, all doctors, and try and strengthen ourselves so that we are able to deliver something where there's no success 100% guaranteed. Because that's one question which every patient asks: what is your guarantee for a success? My guarantee is only for my good positive performance with all kinds of positive available techniques. So that's something which is very important.
You've given a very good example. What the role of a doctor is during this process, that but keeping in mind the lack of faith that people have in the medical system today is something that needs to be worked on. And I think the one responsibility that every doctor has is to build faith that I will do the right thing for you. So that brings me to the next question, Dr. Gauri Devi, and when we are talking of the unpredictability of the nature of treatment that it is, how do you ensure that the patient does not give up and quit when you know that things could work out? And on the contrary, also my question is that, when is the right time to tell the patient that, listen, I think it is medically not possible. So there is no point in trying.
See, the thing is, when we have the embryos, we tell them and we go through them, even in the best of the centers globally, 25% dropout is there. Even then, once they do it, they just don't want to come back. That is their mental makeup. But we, from our side, what we do is we give them a very positive attitude. Look, you have got embryos with you. You have got oocytes with you. Try once more. And many of them understand it. There are certain conditions wherein we know this is not going to work. We tell them either you go for a surrogacy or you give up, you go for adoption. Even then, they will insist, try one more time. I want to conceive. I don't want a surrogate. So it is and sometimes they are right. We say you might be wrong. I tell them, please don't, I don't think you will conceive. No, doctor, try once more. And she's conceived and produced a child. So I always respect her thoughts. Tell them this is the probability. Here, this is the probability. It is better you take, but if you still feel that you want to try, go ahead. So that way, there's a transparency and they accept it quite well.
Got it. And this is very important. It actually leads me to another question. Dr. Samir, you might want to share your views on this. And this is not the question I had in the list. I'm actually writing a book on cancer. And what I'm trying to study is that, people who survive versus people who don't, despite the same doctor, same prognosis, same medical treatment, etc. What happens inside of the body to give you that strength to want to live? Now, that same case, does it work here as well? I mean, I'm taking a cue from what Dr. Gouri Devi said that, medically, you think it is not possible, but there's something inside the body that makes you feel that, listen, मेरे को पता है, मेरे को पूरा विश्वास है कि हो जाएगा,
I think you raised a very pertinent question. As doctors, we also believe in miracles because we are also human beings. There's a lot to do with positive thinking process. And when we say positive thinking process, let me talk about some biology here. When a person is depressed, when we are not feeling good, we talk about inflammatory responses in the brain. We talk about free radicals. We talk about free radical injury, right? Stress has become an independent risk factor for many lifestyle-related diseases. Cancer is one of them. The prognosis is also dependent on how good or bad you are in terms of coping with stress. So all this put together, I would say a very positive mindset is the requisite for, number one, preventing many illnesses related to the medical field, or when we talk about dynamics, the dynamics of relationship also. And it's also very, very important in terms of the prognosis that we see of any particular illness that a person is going through. So as counselors, as psychiatrists, as psychologists, our role is also very, very important in terms of being a part of that team, right? The medical team, being in tandem, making sure that we encourage the patient all through the journey, and we are able to achieve a better outcome in the process. We've seen it. I mean, working in multi-speciality hospitals, we work across disciplines. There's a lot of crosstalk that happens, wherein many a times, my colleagues working in other specialties would say, no, it's better you also consult the psychiatrist. Initial reaction is a big no because of the stigma at times. But then when they make them understand biology and biological reasons for whatever physical concern they are coming up with, I think they are much more receptive. And when they come to me, I talk about neurochemicals more than putting a diagnostic label, because many a times people are not very comfortable. And even if they are very keen to Google serve things. And then they extrapolate all the negative information on the net, which we used to call as third year syndrome, happens to all of them. So I often tell them not to consult Dr. Google. And we talk about neurochemicals. I say that at the end of the day, I understand you are maybe low on serotonin and high on dopamine. Let me work on those chemicals, and I think we should be better. And I think they take that advice in a much positive way, and we see good results when we try to work on their mind alongside the body, because they're all interlinked, they're all intertwined, and this interlinkage is through neurochemicals, hormones, and the immune system.
You just spoke about, we were talking about positive thinking, but what about cases where IVF has failed, or doctors have told them that, listen, in my opinion, there is no merit in trying or going in for another cycle? Do these patients get referred by IVF specialists to you saying that I think you should consult, without making them feel that, kuch galat ho gaya hai? And because these are the people who suddenly tend to get into depression, anxiety, etc. So how do you deal with these kind of situations where they've been told that it is medically not possible, or I think it's time that we should not be doing any more IVF cycles?
See, before we guide such people, we first try to understand from the IVF expert as to where the failure is happening. That's the first thing. So that crosstalk is very important. Do we need to assess the personality profile of the people who are coming to us? What level of understanding have they got despite being counseled by the IVF expert? Where are they stuck? We try to build hope and make them understand that there are other options also which are feasible and no less appropriate given that point of time and the scenario that they are in. It's about acceptance. So we have to basically move them from a state of denial to a state of acceptance and to a state of positive acceptance. So there are different options these days. And why not explore other options also?
Right.
At times they're stuck, they're obsessively stuck. Some of them might need medication. Some of them might just need counseling.
Got it. I think this is extremely important because, this could be one of the causes for stressful relationships as well. Dr. Jaideep, you wanted to make a comment?
Yeah. No, I actually was, these are like everyday questions for us. And I always ask the couple, why do you want to have a baby? First thing is, which is very, very important for me to understand, they'll come out with 100 types of answers. मेरे को अग्नि कौन देगा? मेरे को बुढ़ापे में कौन मेरा ध्यान रखेगा? Now, and I tackle them accordingly because right in the beginning only, the moment they say मेरे को कौन अग्नि देगा, मैंने कहा कैसे पता लगेगा कि जब मर गए कौन अग्नि दे रहा? आंखें खोल के देखेंगे भैया? नहीं देखेंगे. पानी में गिर के मरे तब कौन अग्नि देगा? So they need to understand that there's some mindset which they come with, they need to change. Then मेरा ध्यान कौन रखेगा? Then I always tell them that very near to our hospital there is one old age home where hundreds of old parents are there who have children, like 4, 5, 6 children, but they're lying in that old age home. So what are you saying? Your health lies in your own hands. Family is important. Please have a baby, but not with these thoughts in your mind. And that's something. And plus, don't put the load on the child's head that you will take care of me when I get old. No, you take care of yourself now and prepare yourself for your old age, which is important. So, when these conversations happen, a lot of clarity comes in their mind. And I think it is my job that I should do it.
So I think it is very nice because you must understand and have a baby for the right reasons. And these are all frivolous reasons that we try to give to ourselves based on our societal pressures. Dr. Madhumathi, let me come to you. The last time I asked you a question, it ran into a debate, but let me spark this again. At times, first is a woman or a man does not know, or they are in denial that, infertility could be an issue that they could be dealing with sometime in their life. Because, we are appearing to be very, very healthy. And this is not the thing that comes to our mind until we actually get married, or until a very later part of our age, even if you are not married, because then you want somebody to take care of you, like Dr. Jaideep said. So it is, and then when you take an insurance, there is a list of cool off period that 24 months you can't do this, 24 months you can't do that. But fertility treatment is something that people come in as a last resort. First is they've tried on their own. It does not work. Then they go to their pundits, they go to their astrologer, then they go to their babas. And then nothing has worked. Then they come to a doctor as a last resort. By that time, they don't have an insurance. And then there is a cooling period if they want an insurance. What is your point of view on how can the insurance industry work on something which is very specific to Indian societal norms? What is a reality?
So this is precisely the problem of the industry, what you just touched upon. People hesitate to insure early, like they come to the doctor at the last moment, right when things go really wrong, after consulting Google Baba or Dr. Google, and then they come, at the end point to the doctor. Likewise, they hesitate. For example, you take a preventive health checkup. People hesitate to go for a preventive health checkup unless somebody says you might be suffering from some kind of, medical condition. So it is always an emergency or some stage where the treatment is complicated or not possible. So then the whole entire cycle gets triggered. So insurance ideally has to be taken upfront. For example, you purchase a car. What do? You take an insurance upfront. You don't wait for the accident to happen, then take an insurance cover. Similarly, it is highly unfair to the precious life that we are holding that we are waiting for the moment where everything is complicated, everything is stressful, the finances are mounting, the gynecologist has said go for ART. At that point, you think about insurance. So that is why I would repeat my statement, though it is a repetition. Young people should come forward like the Western world to insure themselves when they are healthy, so that if at all, see, insurance works on the concept of risk pooling. See, what we do is we contribute, many people contribute premiums that will create a fund which will help the few who actually need it and who actually suffer a disease. So the more the people take the product, the more awareness, the more establishments, clinical establishments coming up. Now we have a handful of recognized infertility centers. Now imagine every hospital has got the recognized expertise, the recognized establishments, and more population taking the product. So the accessibility improves, the affordability improves, the so-called cool-off period, the 1 to 4 years for the pre-existing condition, because it becomes an anti-selection when we are catering to a small population. We want to cater to a large population where we can, factor in affordable premiums to people, and they can benefit by lesser waiting periods or cool-off periods. That will happen only when the penetration increases and the awareness increases. That is very, very important.
Madhumathi, my next question to you is that, what I've seen is when you look at people who are either uninsured or are not adequately insured, with the asset-light models that we have seen coming, some of these companies have become really large. And they don't want to lose the patient, or they don't genuinely want the patient to not try or get a treatment because there is no money. So while one option is that you pay the premiums until the problem arises and then the insurance company is there, the next model that I've seen evolving subtly is that, you get your treatment done and then you have EMIs. So most of the large players are becoming finance companies of a sort, where they say, okay, you create an EMI plan and then you can pay us later. Do you think this will happen in the fertility space as well?
See,
if insurance does not take notice of this right now?
It's a little, see, as I said, we have just taken the baby steps towards the coverage. A lot is evolving. So we are also in the process of, see, even after this meeting today, with the experts here, we will take the inputs forward to our product and actuarial teams. So they in turn will take the inputs to the regulator. So it has to be, there has to be some selection and risk pooling that has to happen. So going forward, we have to see how we evolve and emerge. So that's a tricky thing to answer right now at this point of time, where we have just ventured into that, area which is not entered so far by insurance.
Absolutely, but it's such a pleasure to know that, you're taking it in such a positive manner that you're willing to take the feedback to the company and embark on that journey. Yeah. Thank you so much for that. Dr. Jaideep, I want to ask you the same question. Do you think in tier 2, tier 3, and you're operating, in tier 2, when financials is a problem for the treatment, do people ask for payment options which could defer or create an EMI?
Yeah, they do ask, and it's all the time. But the important aspect is that how do you really offer? So, I, as a private practice clinic, I will not be able to run after people if I have given them a deferred payment scheme, once the result is negative, they'll never come back and pay. So I actually evolved my own system that, and I don't know whether the public is aware or no. We doctors are on an everyday basis giving so many discounts to the various strata who come to us. So I actually evolved that every month I'm going to do about 3 cycles free, where I don't charge my fee. We do have a lucky draw in our clinic every 10th of every month. And everyone who is registered in the previous month goes through that lucky draw, whoever wants to participate. and then I don't charge them. This is just one part of it. Even our federation from the Indian Society of Assisted Reproduction, we are encouraging people to do at least one cycle free, whoever is a member of our organization. And I know that many of our friends are also, doing this. These are very small contributions from us. But on a daily basis, a lot more happens. Because so many times a couple will come, I don't have charges for freezing, but I want to freeze. I'll just give you one small example if we have time. Here, one couple came about 2 months back, and they went through a cycle, young couple. They went through a cycle, and on the day of the transfer next month, they said, no, we are not going to do it. Please destroy our embryos, and we are going for a divorce because this is something which, we are not getting along together. They wrote and they said that destroy our embryos. And I said, okay, once they were moving out after having talked with both their parents and all, I said, okay, you've written it down, but I'm not going to destroy them. I'll keep them for 6 months and then we'll see whatever happens. They come very next month and they say, no, doctor, we are fine. Now please transfer. I said, no, I will not transfer. I'll transfer only after 6 months because you still need to prove yourself. You're right now very unstable to even have a child. These and how much actually expense has already gone in before even going for me to a stage where they will pay and they'll get a transfer done. So these are issues which we face every day. But I think all of us, as you said about doctor-patient relationship, for me, my patient comes first. Rest, everything follows. I try to help them in the best possible way, which I can. We've all reached a stage where money is important, but is not as important.
Right. Dr. Sameer, let me come to you before I ask my last question to the panel. The thing that comes into my mind is that a couple of things that are actually creating the need for IVF today is late marriages, delayed pregnancy. Do you think there is a need for creating awareness on these social issues? Do you think it will be well accepted, or it is something that we need to do so that people don't, like we are talking of prevention is better than cure. This is something which is an outcome of a lifestyle change that is happening.
I think you've raised a very important, pertinent question. And when we address such social issues, I think if we add an element of biology to it and an element of science to it, which is true in a way, isn't it? So if there's a delay in planning pregnancy, then obviously your quality of sperm, the quality of eggs isn't very good. The chance of you conceiving becomes poorer, isn't it? At times, the IVF failure rate also increases. So when we're looking at all those things, why not plan in time? Why play with nature? Today we are talking about only career, and at times we are just relating success with material possessions. So that brings us to the concept of human life and the way we have evolved over a period of time, where we are trying to control everything around us. And when we try to play with nature and we try to control things which obviously cannot be controlled, nature is much more above us. I think we have to accept reality and nature to some extent as well, isn't it? Then only the scientific advancements are also going to help us to a much better extent. But when we add biology and the biological understanding to the social cause, I think the acceptance is much better amongst people.
Right. And Dr. Sameer, what would
and it's not about fertility. We also know that if the age of the father, when you're planning a child and the age of the husband is, say, approaching 40 or beyond 40, then the risk of autism in a child also goes up, isn't it? When the mother's age is, say, 40 or above, then the risk of Down syndrome in child also goes up, isn't it? So there are many issues which do come up. It's not just about not being able to conceive. It's also about other problems which can arise because of advancing age in both the parents. So those are, I think, so everything in time is, I think, better rather than delaying it too far and trying to control things based on our priority for materialism rather than for the natural normal flow. Like the doctors in the panel also said that, the husband would only come once in a week just to make sure that, he has done his job. Now, this is not the way pregnancy is intended to be, and the way it happens. So when we are trying to control everything, I think in that attempt to control, in that obsessive urge to control, we are losing control over our own selves.
Right. Very valid point, and I think very well said. Dr. Jaideep, Dr. Sameer, let me begin with you only. My last question to all of you is not even a question. It's a request for a positive note on the World IVF Day that you would want to share with a couple who is looking for fertility treatment to embark on a new life towards parenting.
So I would say they must keep their calm. They must be together in this process, not only as a couple, not only as a family, but also with the doctor. Like said, that doctor is like a sarthi there, like a mentor, like a guide, who's also silently present all through in that journey and is equally affected with the outcome. Prepare them in a positive way. And I think it's a lot to do with trying to control their own self rather than control their partner, isn't it? Whether it's lifestyle, whether it's expression of emotions, and that positive environment is going to yield positive outcome.
Got it. Dr. Gouri Devi, what would be your comment?
My comment, in spite of all the discussions we have had, let me tell you, the results of IVF in India, it is as equivalent to global results. So we have got very good specialists. We have got very good centers. Now that the ART regulation male surrogacy has come in, once it is standardized, we are going to be really good. And the patients, only thing is that accessibility and awareness, we still, a little way behind compared to the villages, the third tier cities. So if we can reach out to them, I would tell them, definitely India is progressing in the ART sector, and we have got good centers with good results. Rest is their luck. So they should not have any negative feelings. Go with the positive feelings and achieve what they want. That would be my take.
Lovely. Dr. Jaideep Malhotra, what would be your message?
I would say like families are very important. And we must, strive to maintain that balance in the society for the national interest and so on. But our health is our prerogative, and we must optimize our health, which is very important to achieve what we are really going to achieve. And second important aspect is that let us not follow the West. Our country has our own issues, and I would say that, when we follow the West blindly, there are many factors which are going to really become a hurdle, and everything has to go hand in hand. So we see couples, delaying pregnancies. I don't really believe in that, and I would really say that do not fear anything. Hope is actually the only stronger aspect of fear, and faith is something which is going to really take you much forward. Don't look at the staircase, just take the step. And the journey is important. Even if you have not achieved a baby, it doesn't matter. You tried, you did your best, is something which is more important for the journey of life. And I am talking about it from a very, very spiritual factor, because I know loads and loads of people go with that load on their head. Oh, I never tried. Do try. And once you try, when you plunge or take a plunge, head is definitely going to come.
Lovely. I love that message. Take that step. Don't look at the staircase. Dr. Madhumathi, I'm going to use that same thing for you to address. That was step to le liya, but wo staircase climb karna expensive hai. So what is your message on the IVF?
I would just say 3 small things, though very important. Invest in your health. It's totally worth it. And insure early and stay healthy. And in our country, the basic necessities to live are food, water, shelter. I think that should graduate to food, water, shelter, and health insurance, so that one can face, any unforeseen event with confidence. Thank
Absolutely you. Brilliantly put, Dr. Madhumathi. You know what, doctors, this has been such a beautiful and useful conversation. I'm sure anybody who's watching this will really find value in because we've been touching on aspects beyond the treatment itself. It's what people go through when they are going through the treatment. And my only this thing is that, while we are seeing the negative, the challenges, which is the late marriage, increased pregnancy age, but there are certain positives that we have seen in the society. One, there's a rising disposable income today. Like Dr. Madhumathi said, invest in your health. It's extremely important. Second is, while there is not enough awareness, but we are on that journey, there is more awareness than what we had seen a decade ago, especially related to, IVF or infertility, because we are finding more acceptance in the families about infertility, which is why the treatment of fertility is going up. And also, the last but not the least, what we've seen is that the technology advancement that has happened is actually helping us create better outcomes, better results, which is bringing back the faith in the healthcare system, not just the doctors. With that, I'd like to thank you all for joining in, Dr. Jaideep Malhotra, Dr. Gouri Devi, Dr. Samir Malhotra, Dr. Madhumathi, Ramakrishnan. Thank you so much for taking out time to join us today. Thank you.
Thank you, Dr. Narula.
Thank you so much.
Thank you for having us. Thank you.